Hello and welcome to May Grand Rounds. I'm Carol Rockhill, and along with Mendy Minhar as a coordinator for the Grand Rounds. I'm actually going to share, Chris, so I may kick you out of sharing, sorry. And because we are here in Seattle on the land of the Duwamish tribe, we would like to acknowledge that this is the traditional land of the first people of Seattle, the Duwamish people past and present, and we do honor with gratitude the land itself and the Duwamish tribe. And also we do want to affirm our commitments in the psychiatry department that we are aware of privilege and oppression and are becoming, trying to be more aware and more intentional about acknowledging and addressing those and how they play a role in the lives of patients and employees, and that we have a commitment to improving care for patients with social and economic disadvantages. Regarding the tribe itself, we do have a couple of ways that people can support the tribes. One is Real Rent Duwamish, which is a place you can go and commit actual rent per month to the tribe, and we encourage you to do so if you're able. And then also the Duwamish tribe is seeking national recognition, and so if you go to their website, there is a petition that they have if you to support that, and you can also shop there. I did want to make a couple of announcements before we start the Grand Rounds presentation. The first one, trying to advance my slide here, is, go back, is that today is Maria Felinchek's last day, and she has been the Grand Rounds coordinator, our administrative support, and just an extremely competent and really amazing at her job, Grand Rounds coordinator since 2015. And every speaker, I think, has a really positive, as far as I'm aware, a very positive interaction with Maria for a month leading up to the Grand Rounds presentation, and she really has represented our department well, consistently and nationally, with a lot of people who have come and given Grand Rounds for us. And as many of you know who are on faculty, she's also done an amazing job with coordinating the call schedule since just before she started with coordinating Grand Rounds. So I did want to say, Maria, that we will miss you, and we thank you for all that you have done for us. I did want to also let people know that next month, June, is going to be the last month of this series of Grand Rounds. We go October through June, and that presentation is going to go over our usual scheduled time. It's going to run until 10 a.m. And that's because it's the presentations of the scholarly inquiry projects of our child and adolescent psychiatry fellows. This is the first time that we're using Grand Rounds time for that presentation. Typically, it's a separate time. And so we thought that would be a really nice way for the child and adolescent psychiatry fellows to have a bigger audience and more exposure and discussion to the projects that they work on over the 2 years that they're here, and often are impressive, and we want you to know about them. I did also want to let you know that next year, Mendy and I are in the process of planning the season that will start in October, and that we are anticipating it being hybrid, that we will try to have as many as we can of the speakers be in person at Wright Auditorium, but also we'll still have the potential to do what you're doing now, logging in from home or from wherever you are. Because that June, there is no faculty meeting today, and in June, we anticipate the faculty meeting being later. I think 10:15 to 11 is what is being planned. Any questions or comments about that before I introduce Alicia to introduce Dr. Lane? Okay, then I would like to introduce Dr. Alicia Thompson, who many of you know. She is the clinical director of our inpatient psychiatry unit. And I did want to point out that Alicia has just recently been awarded the Society for Clinical Child and Adolescent Psychology award for promoting evidence-based mental health services for children and adolescents, which is a national award. And so I thought this would be a good moment to congratulate you for that, Alicia. And she has a strong connection with the topic that Dr. Lane is about to present for us, and she will introduce him.
Thank you, Carol. Thanks for having me to present Dr. Christopher Lane. As many of you know, I'm very passionate about child and adolescent trauma and what we can do to improve the lives of kids who have experienced trauma over the course of their life. So I'm excited to introduce Dr. Christopher Lane, who is a clinical psychologist and associate professor of psychology at Nova Southeastern University, where he directs the Child and Adolescent Traumatic Stress Program, a training clinic that specializes in the assessment and treatment of traumatized and bereaved youth. He's also the principal investigator of the National Child Trauma Workforce Institute, a large federally funded institute dedicated to adapting and disseminating the core curriculum on childhood trauma across the U.S. Dr. Lane served as program director of education and evidence-based practice at the UCLA Duke University National Center for Child Traumatic Stress for 15 years. In that capacity, he led the National Child Traumatic Stress Network core curriculum on childhood trauma. The core curriculum is a major initiative designed to raise the standard of care for traumatized youth and families across the U.S. by raising the standard of education and training of mental health professionals who serve them. Dr. Lane has also co-authored over 100 peer-reviewed journal articles, chapters, editorials, and over 200 conference and expert panel presentations. Dr. Lane and his colleagues work closely with the American Psychiatric Association to create developmentally informed criteria for prolonged grief disorder in the DSM-5 TR. He has co-authored the Manualized Interventions of Psychological First Aid, Focus for Military Families, Skills for Psychological Recovery, Trauma and Grief Component Therapy for Adolescents, and most recently, Multidimensional Grief Therapy. Dr. Lane is the lead developer of multidimensional grief theory and various trauma and bereavement assessment measures. With funding from such agencies as the Substance Use and Mental Health Services Agency, UNICEF, New York Life Foundation, the Kennedy International Studies Center, and the New York State Office for Mental Health, Dr. Lane has disseminated manualized interventions on an international scale and co-led the nation's first practice research network of bereavement centers. His professional interests include traumatic stress and bereavement, professional education and training, developmental psychopathology, evidence-based practice, evidence-based assessment, theory building, research methods, and trauma and bereavement-focused intervention. So thank you, Dr. Lane. We are so excited to have you here, and I will turn it over to you.
Great. Thank you very much for a lovely introduction. Do I need to reshare my slides? Looks like I do.
Yeah, you do.
Okay. Can people see things?
Yep, we're seeing your slides.
Good to go?
Looks good.
Okay, good. If people can turn off their volume, then I think we won't have any reverb and we'll be good to go. Great. Thank you so much, everybody. It's been a lovely time working with you thus far. I'm excited to present to you today on something that has been near and dear to my heart since 2006, and that is the core curriculum on childhood trauma and using it to strengthen trauma-related competencies in the national mental health workforce. So I want to talk about some of the work we've done in the last 15 years, as well as lay out a vision for the future. In terms of acknowledgements, a lot of people have contributed to this in various capacities, and I just want to acknowledge them, as well as the Lytle Hill Institute for Human Resilience at UC Colorado Springs, where our current SAMHSA grant is housed. In terms of disclaimers, there are a number of things that I'm involved in that may at least obliquely relate to what I'm going to be talking about today. With respect to a professional practice gap, this is where I'd really like to start drilling down. There are many errors in professional decision-making that stem not from deficiencies in content knowledge, but rather from deficiencies in clinical reasoning. And I'm going to make a case for that in just a couple of slides. The core curriculum on childhood trauma uses best practice instructional design principles to strengthen a broad range of professional competencies in learners. And these include the ability to gather, integrate, and use both case facts and the empirical evidence base to guide clinical judgment and professional decision-making. I want to emphasize right here, the core curriculum is not and is never intended to evolve into a manualized intervention. It's just simply not another version of, say, your favorite trauma-focused treatment. It is something that is designed to serve as a frontispiece and an accompaniment to training and manualized treatment. In terms of today's learning objectives, I'd like to describe the pressing need across mental health disciplines to ensure that clinical training encompasses not only content knowledge, and that's basically a lot of the knowledge that you need to pass your board exams, but also clinical reasoning skills and professional judgment, which oftentimes is what you need to be able to truly help your clients and your patients. And to describe the basic elements that make up the NCTSN, that's the National Child Traumatic Stress Network core curriculum on childhood trauma, which we really launched back in 2006. And to explain the primary role of each of the elements of the core curriculum in strengthening clinical reasoning skills and professional judgment. So I'd like to begin by posing a question to our audience today, and that is, why are critical reasoning skills so important? And to be honest, in some ways we're jealous, because in medicine, you have more hard metrics to be able to gauge the success with which people are being able to are succeeding versus failing in providing quality care. For example, McCary and Daniel back in 2016 published a study that showed that medical errors, that is errors in clinical reasoning and clinical decision-making, were the third leading cause of death in 2013. They're only behind heart disease, and they are ahead of COPD, suicide, firearms, and motor vehicle accidents. This is obviously a sobering national issue. And interestingly enough, if you read up on the results of procedural autopsies, and that is when they really try to break down the procedural decision-making processes that led to medical errors that resulted in patient deaths, they reveal in the majority of clinical decisions that resulted in patient fatalities, errors in clinical decision-making arose not from a lack of clinical knowledge, but from a failure to correctly apply that clinical knowledge that the practitioners already possessed. And that basically means that you can memorize lots of things and pass exams. And I also speak as a licensed clinical psychology. There are a lot of things that you know that can get you by your exams that are not necessarily going to adequately prepare you to be able to work with patients and to help them. So if we're trying to drill down into the implications of these procedural autopsy findings, practitioners not only need content knowledge, they also need specialized training in clinical decision-making skills too. And here's a long list of things that we've tried to build in the core curriculum to help them apply that knowledge in appropriate ways. And these include clinical assessment, gathering relevant case facts and formulating good questions and hypotheses; case formulation, organizing and integrating gathered case facts into a working clinical theory; critically evaluating and weighing the evidence to make informed decisions, oftentimes deciding for or against a given hypothesis or course of action; treatment planning, and that is acting on the clinical theory and putting it into practice; monitoring treatment implementation and client response. Is the intervention being rolled out as planned? Are clients or patients progressing as planned? Or is a course correction needed? And surveillance for new or recurring major life events, including stressors and beneficial life events, things that oftentimes are not present at the beginning of treatment, but that we have to be aware of. In many cases, we're working with very socioeconomically disadvantaged populations living in difficult areas, and it is not surprising at all for new adversities, as well as sometimes beneficial life events, to occur during the course of intervention. Do we even detect them, for example, and are we able to integrate them into our case conceptualization and treatment plan in ways that allow us to leverage them? So our primary aims with the core curriculum on childhood trauma are to deepen content and conceptual knowledge of childhood traumatic stress. We want to make more knowledgeable and evidence-informed decisions. A second area is to strengthen critical and clinical reasoning skills, and that is the processes through which we make decisions. We want to be able to reduce bias and blind spots and illogical and or unsubstantiated assumptions. We want to also make more evidence-based, logical, and confident professional decisions. What I like to say is we want to be able to build confidence intervals around our decisions in the same way that we build confidence intervals around test scores in psychology, and that the width of the confidence interval should be roughly commensurate with the amount of substantiating evidence and the overall degree of confidence we have in our decision. And further, we want to improve professional judgment and decision-making. That is, we want to make better professional decisions, things that minimize the likelihood of patient harm and maximize the likelihood of patient benefit, and to make more accurate predictions, including diagnoses, prognoses, and treatment plans, and so forth. I want to underscore that these aims are aspirational. This is definitely a work in progress. I would say we are only maybe 30 or 40% towards what I'm really aspiring towards during my tenure here. There's overall a key question and need, and this is stated well by my friend Steve Berkowitz. What could a practitioner who has been trained to implement a trauma-focused treatment protocol with fidelity still not know about traumatized children and families that is essential to truly helping them? So this is really predicated on the assumption that training in manualized interventions, although very important, with fidelity, of course, and that's associated with improved patient outcomes in general, is by no means an adequate education to being able to work with this very challenging population. Excuse me. So I'm going to give you two examples of clinical blind spots in clinical reasoning and judgment that we try to address in the core curriculum. Things clinicians trained in evidence-based trauma treatment protocols may still not know that are nevertheless essential to good care. So here's the first one, and that is being able to identify the effects of complex trauma and developmental cascades. So let me ask you this particular question here. Do simple checklist tallies of adverse life events like ACEs, I'm hoping that people have learned about those, tell us what we need to know about the effects of trauma across the developmental life course? So let's begin with a thought experiment. And these are two different scenarios that I personally created, but are nevertheless highly representative of many of the clients we see throughout the National Child Traumatic Stress Network. And I'm going to give you a hint first and foremost. Both of these children's histories have an ACEs-like score of 7. And oftentimes, frankly, people like to just simply tally ACEs and just use that as a rough quantitative index of the degree of trauma severity, et cetera. We have rather grave reservations about the overall clinical utility of using that as a decision-making tool. So my first question is, both of these have ACEs scores of 7, but do they tell similar clinical stories that carry similar clinical implications? Here's the first one. I'm going to be using the UCLA Reaction Index Trauma History Profile. What kind of a story does this clinical profile tell? So here's the trauma history profile and roughly interpreted. We've got age in years. These are all years of age, these columns right here. And it's broken down by something like 20 different types of trauma exposure right here. And if we're starting to map out the sequence by which these occurs, it starts with an impaired caregiver in the first year of life. And then we have a piling on effect. And by the way, that has a duration through about age 5. We don't know exactly what happened, but it appears to cease at that age. Second, we have a piling on effect of emotional abuse, which joins that. Third, in the next year, we have domestic violence and physical maltreatment and abuse joining. Then fourth, we have neglect. Then we have domestic violence joining fourth. Fifth is sexual maltreatment or abuse. And sixth is sexual assault and rape that occurs at age 14 and persists for several years. So what does this actually tell you if you're trying to get a read on this? And let's contrast this with another story, once again, that has an ACEs-like score of 7. And that is, let's take a look at this. We have a childhood that is actually free of early childhood traumatic experiences, but at age 10, frankly, all hell breaks loose. We have neglect going on. We have war, terrorism, and political violence. We've got trauma, traumatic loss, or bereavement. We have forced displacement and an impaired caregiver. And these have a duration of several years that have a duration through age 15. Then we have community violence and school violence. So what do these two clinical case scenarios actually tell us? If you walk back, this is sort of your classic complex trauma scenario of a child who's born into a chaotic and dysfunctional family environment and has many early developmental insults. In this one, we've got a child who actually was raised in a happy, healthy community, and then war broke out. This might be Ukraine. A Ukrainian survivor who actually had a happy childhood and is now having all hell break loose and is going to live in a refugee camp, for example, for a while, and then they move to a community where there's community violence and school violence. So my question to you is, given the respective trauma history profiles, are these two cases at equivalent risk for severe persisting distress? functional impairment, risky behavior, developmental disruption, and destructive developmental cascades across the life course? Do they call for the same types of intervention? Why or why not? Now, if we had time, actually, this would be a situation if we were conducting a core curriculum training, we would break out into breakout groups and discuss these things in detail, and every group would have a chance to report in and talk about their deliberations, their decisions, and provide substantiating rationale, why or why not. So for us, once again, we're focusing not on content knowledge just in terms of facts, but also a lot of conceptual knowledge as well. And for us, one of the key concepts we're trying to get across with thought experiments like this is to help people learn to think like a developmental psychopathologist. And that is to be able to superimpose children's trauma histories under the developmental histories and then to consider their dynamic interplay over time. And the idea is that the earlier the developmental disruptions, the more these can cascade in pernicious ways, in pernicious developmental cascades across developmental periods in ways that can impede kids' ability to be able to take on and successfully achieve subsequent developmental tasks, et cetera. So you have a cumulative effect that has not only of trauma history, but also of accumulated developmental disruption. And that can cascade forward well into adulthood, et cetera. So if we learn to think like a developmental psychopathologist, we don't simply want to count your ACEs. We want to think about things like developmental tasks. Which tasks are currently underway? Which tasks are recently completed and might be susceptible to developmental disruption? What are the salient life domains in which these developmental tasks are currently being worked on? Is it romantic relationships, for example, or entry into the workforce as a teenager, for instance, or movement into early adulthood as kids graduate from high school and move on to college, et cetera, focusing on those developmental transitions, et cetera, as well as trajectories, and that is the course of adjustment plotted over time. Pediatricians know how to do that with respect to a lot of developmental parameters. Are we able to do that with trauma-relevant parameters as well? So we can not only think about mental health problems in terms of symptoms of psychiatric disorder, but we can think about these in terms of developmental injuries, in ways in which they can cascade forward over time and create a snowballing effect. Here's a second clinical blind spot I'd like to give you an example of, and that is this kind of a cascading effect that we could find in our own clinical decision making. And that is, if I'm going to invite you to look for this in the scenario that I'm going to give you. But under detection of trauma and bereavement-related histories, for example, we have flawed risk screening tools and procedures. We're just simply not using them, or frankly, they're too basic. They're not well designed. They don't map well onto the problems that are endemic to the populations that we're treating. And inadequate clinical assessment tools and training for our staff can cascade forward into erroneous decisions in terms of underdiagnosis. We've got false negatives, for instance, or misdiagnosis. We may actually misdiagnose trauma-related difficulties as, for example, a disruptive behavioral problem and not see the connection with the traumatic event and with current ongoing reminders, for example. And erroneous decisions in terms of diagnosis can itself also cascade forward into other erroneous decisions in terms of undertreatment or mistreatment. So my question to you is, don't standard assessment procedures do an adequate job of detecting stress-related disorders? I'm simply going to provide one study that was conducted a few years ago. Forgive the very busy slide, but I'm trying to summarize all this in one page. Claude Kemtob et al. Evaluated the accuracy of clinicians working in a community mental health clinics in identifying trauma exposure and PTSD in 157 children. The children and their parents were assessed twice. First by a clinic practitioner using a standard intake assessment, that is using standard tools and standard training. Second, in a follow-up by a study clinician using a structured trauma-focused assessment. That is they were equipped with proper tools and with proper training. 6 key findings and implications emerged. 1, although mandated to assess trauma exposure is required by state law, clinic practitioners identified less than half of the youth identified by trained study clinicians as having trauma exposure. Second is clinic practitioners identified PTSD in 1.9%, and study clinicians reported 19.1%. In other words, they missed 90% of the PTSD. Third is, although clinic practitioners had access to the assessment results in each client's chart and were required to update their treatment plans on a quarterly basis, a one-year follow-up review identified no changes in their client's PTSD diagnosis. And that is, assessment was done one time, it was static, one and done. They didn't revise it, even though the data were available in the client's or in the patient's charts. Fourth is, diagnostic signs were nevertheless apparent. Clinic practitioners and parents rated underdiagnosed children as exhibiting emotional and behavioral problems and lower functioning. And clinicians reported seeing the indicators, but they missed the diagnosis and an opportunity to prescribe appropriate treatment. So one sobering conclusion of this is that standard assessment procedures missed more than 50% of the trauma exposure and 90% of the PTSD cases. It did not course correct, even though accurate information was available and regular updates to treatment plans were required by clinic policy. So one key implication here is that we must ask about trauma history or missed PTSD. We must ask about bereavement history or missed prolonged grief disorder, a brand new grief disorder that's now found for the very first time in DSM-5-TR, which came out a little more than a month ago. So let's talk about what the core curriculum is doing to help us make course corrections in this regard. We want to be able to improve professional decision-making on a variety of different levels. So there are two primary applications of the core curriculum. One, if you focus on the big blue box right here in the middle, training in manualized trauma-focused interventions, we're not trying to displace that. We're just simply actually trying to complement that. One is this can serve as a foundational prerequisite to training in this, and that's oftentimes embedded as an integral part of training in graduate school. They're exposed to the core curriculum first, and then they're trained in manualized trauma-focused interventions. We have a good number of case studies coming in from the field that report that the supervisors of students who are being trained in manualized trauma-focused interventions note when the students themselves are trained in the core curriculum, because they oftentimes just get it better, they get it faster, they get it deeper. They ask better questions, and they're much more adept at being able to formulate a good case conceptualization and to be able to specify good intervention plans and to lay out the logic that interconnects all these different levels. And the second is ongoing professional development. You can think about that as in-service training of practicing professionals who are interested in augmenting their abilities, for example, in working with a broader age range, with different cultural or racial groups, for example, different types of trauma or loss, et cetera. Another way to think about this, and once again, this comes from Robert Pinus, the curriculum complements training in manualized interventions. You can think about training in manualized interventions as an inverted pizza slice or an inverted pyramid. Strong on skills, how do you do it? Moderate on components, what are the constituent elements that make up the intervention in terms of intervention objectives, what we want to achieve, and practice elements, how we try to achieve them, the strategies that we use. Not much focus on concepts, to be honest, because the training time is typically limited. The core curriculum is heavy on developing a deep conceptual understanding. We also can teach people about core components, but those are linked and are taught as logical implications of a conceptual understanding and of the evidence base. Not much time we give in the core curriculum to skills apart from intervention planning skills, et cetera. So I'd now like to transition over and talk about the basic elements that make up the core curriculum on childhood trauma. There are 6 constituent elements. The first are 6 general learning objectives from the core competencies literatures of multiple disciplines. And so we actually culled through, this is work that's done by Hannah Grossman primarily, but all of our team. The core competencies literatures in psychology, child psychiatry, and social work, all of these different disciplines have put out calls for trauma-oriented training and education. We've culled through those and tried to find things that are conducive to training across the disciplines. There are 12 core concepts for understanding traumatic stress reactions in children and families. That's available at nctsn.org. There are detailed case studies, full length, short length, and single page that make this much, much more real and applied, that harness best practice instructional designs in terms of sticky learning. Stories are much easier to remember and to embed key concepts and key principles, et cetera, much more sticky than learning it in the abstract. There's also problem-based learning methods and facilitation. And last is we have instructional tools and assessment tools that are conducive to both formative and summative assessment. The idea is, frankly, we're trying to kill 2 birds with 1 stone. The instructional tools themselves are assessment tools. And so we have various rubrics that we use to evaluate when our students are completing the instructional tools to gauge their readiness to proceed on, meaning that they've mastered a given concept and are ready to proceed on to other more difficult material, or whether they need more time. So let's talk about the 6 basic elements of the core curriculum in turn. The first are 6 general learning objectives. I'm not going to talk about this in detail. This could be itself, the full hour. But applying the 12 core concepts as conceptual lenses, and to learn to put them on like glasses. You rotate in different glasses. It's a little bit like going to the eye doctor and rotating in different lenses and looking at the letters up there on the wall and saying, what do you see? How well do you see, etc. So learning to rotate each different concept in like a pair of lenses and seeing different parts of the case from different perspectives is really an integral part of what we're trying to do. Second is ecological factors, and that is we want to be able to identify ecological factors and to be able to identify what's relevant. In other words, we're trying to build ecological literacy in our learners. My experience in training with UCLA medical students is they're very smart, but oftentimes when you start asking them about patient history, they talk about genetic history, et cetera, a little bit of history, but they oftentimes don't think much more broadly about the larger community and society, et cetera, really trying to build that capacity across all the disciplines. So we think from the individual all the way to the broad meta perspective, irrespective of the particular discipline. Case conceptualization, can we interweave and integrate all these different facts into a working case conceptual framework that does lots of work for us, that describes phenomena, explains and predicts and helps us to be able to therapeutically intervene to control these different phenomena. Fourth is critical reasoning. Can we really make judgments about the relative impact of various factors, for instance? Can we compare and contrast, for example, and weigh the evidence? A fifth is trauma communication. Can we clearly and effectively, accurately communicate with different populations, with our clients in ways that they can understand, that are respectful and commensurate with the basic principles of evidence-based medicine, that they deserve to know and have an integral and informed part in the decision-making about the treatment they've received? Can we adapt it for different professionals, for example, for school professionals and so forth? And real-world application, and that is, can we apply a trauma-informed conceptual lens to real-world aspects of professional practice? So we're constantly trying to get our learners to reflect on how they're going to take these principles and apply them, and to the extent that it's appropriate, to bring in their own professional work. They might be, for example, externs and talking about their particular cases in an appropriate environment and really applying these basic tools and processes to really facilitate generalization to professional practice. A second element are the 12 core concepts. I don't have time to go into these in detail, but this is developed by a task force. So to give you quick examples, the complexity of traumatic experiences, understanding broad context in which they occur, understanding the notion of secondary adversities and life changes and distressing reminders like trauma reminders and loss reminders, a wide range of reactions. Traumatized kids may be withdrawn. They also might be externalizing. How can you make sense of that, et cetera? Danger, protection, and safety. So just understanding all of these different lenses and being able to apply that. Another is developmental neurobiology, culture, challenges to the social contract, which are really important understanding. For example, what's the social upheavals that have been happening in our society in the last few years, et cetera. And then also the importance of good care and secondary vicarious trauma, for example, and the importance of professional self-care. And you can access these on nctsn.org. But once again, these are 12 different lenses, and we work to help our students apply this to cases. A third are the detailed case studies, and they range everything from preschool all the way to late adolescents and their families and their broader communities. These are all developed by experts in these particular areas, and so they have a great deal of rich clinical content. I want to emphasize that the purpose of the core curriculum is not just coming up with a correct diagnosis. That actually might not even be a learning objective at all. It's all about being able to take the evidence and build it into a working case conceptualization and a treatment plan, et cetera. So there's a lot of information in here that goes well beyond simply coming up with the correct diagnosis. The question is, can you come up with a good case conceptualization and a treatment plan that is optimal for your particular client, embedded within their broader family and community? I can give you a quick sample of a core curriculum case study. Most of these are reserved for people who are trained in the core curriculum as facilitators, but this is to the Learning Center, and you can download this case today if you wanted to. It's the Ella case, and it's open for public use. I'll give you one. It comes in handouts. The cases themselves are packaged in handouts that unfold incrementally in ways that we think map on to how you have patient contact in real life practice. Let me move this. This keeps on migrating. Okay, I'm going to look at this quickly. Ella is a 5-year-old who was brought in by her mother, Kate, to an outpatient mental health clinic. Kate came because she is concerned with Ella's frequent and persistent crying, clinginess, and periodic refusal to go to school. Mrs. Zhao is the counselor assigned to Ella's case. In the initial assessment, Kate reports to Mrs. Zhao that she doesn't know how to deal with Ella's emotional outbursts. Ella cries easily over minor things and is difficult to soothe. When Ella hits a certain point, she is inconsolable. Her whole body shakes and she gasps for air between sobs. If Kate is not there, she cries out for her. If Kate is present, Ella will clutch onto her and cling to her limbs. These outbursts are especially likely when it's time to take Ella to school or when Kate is stressed herself. Getting Ella into the car for school is such an endeavor that Ella ends up missing school at least once a week. So that's the presenting problem. There's significant functional impairment. The school finds this so disruptive, they're actually thinking of discharging Ella. And so the case starts to unfold, and you develop hunches and hypotheses, for example, what might be going on. And per a PDL cycle, you cycle through the case and you collect additional information, et cetera. I'm going to telegraph here just simply because this is a quick presentation. This looks like standard separation and anxiety and school refusal. It's not until well into the case you find actually that Ella is traumatically bereaved and that her father was killed in a car accident the year before. And that before then, Ella presented with none of these particular problems. So it's an issue where something looks like one thing, but actually has a significant trauma or bereavement or traumatic bereavement related history. And her behavior takes on a whole new meaning when you understand that history. Okay. Another element is problem-based learning and its facilitation. And that is, we use a 4-step PBL cycle. This is pretty common, I understand, in virtually every school of medicine. But we take incoming facts. The one thing that I've done that I have to say, I have sabotaged this by including hunches, because a lot of cases, especially, for example, CPS cases, are discovered on the basis of hunches and not formal hypotheses, et cetera, but making room in the model for clinical intuition. And so we cycle through the cases using this basic cycle. I can tell you from experience, if you use only this, your learners will get bored after a while. It gets a little iterative and redundant. So we intersperse many different types of exercises, et cetera, to keep things fresh and that really focus on the particular learning objectives. Another element are instructional tools and assessment tools. I'm going to give you kind of a quick read of how we use these. And these are both formative or in-progress assessment while the abilities are being formed, as well as summative, which are capstone and integrative assessment, which is an evaluation about their readiness to graduate from the course, for example, or to proceed on to another difficult skill. So, here's a very standard instructional ecological map. On the one hand, we've got supportive factors. We've got a rough little line right there, and then we have risk factors. So one of the most elementary things to do, this is the basic skill that we have our beginners use, is to start populating this with information. And this is actually from the work of some students taught by Bob Abramowitz and Laura Katz, some of our core curriculum facilitators. But this is just simply proof of concept that students can do this and they can do it well. But to really start to think about our particular clients embedded within broader ecologies and to be able to already start to classify factors in terms of their supportive or risk nature, or sometimes they are fence sitters and it is not necessarily clear cut. And that nuance is something we rejoice in when we see. Now that we've I described its components, how do we use it to build core trauma-related competencies? So how do we use these 5 basic core curriculum elements to strengthen professional competencies in content knowledge, in critical reasoning abilities, and in decision-making? So with respect to general learning objective 1, how do we apply the 12 core concepts as conceptual lenses? How do we do that? Here is one of many different tools that we have. In this particular case, we read through the case and we teach people that hypotheses themselves are logical implications of the evidence that arise from the evidence and that can be evaluated using evidence, oftentimes evidence that's gathered subsequently. So I have them practice, and these are all templates that they can type in real time. They type in their hypothesis, and then they identified substantiating evidence. In other words, what's the evidence from which this arose? And you can continue to add to it as you gather additional evidence. So we're teaching people to use or to generate hypotheses as logical implications of the evidence. That's a rather basic tool, but nevertheless absolutely foundational to teaching our learners foundational critical reasoning skills. Here's an example of what we do in learning objective 2, ecological factors. How do we help them to identify ecological factors that are hypothesized to influence children's traumatic experience and contribute to their post-traumatic adjustment? Well, the case themselves, to be honest, are purposefully over-designed. They have a lot of factual detail in there, and frankly, some of it is peripheral and some of it is central. And this is one of the reasons why we make messy cases, because life is messy, and we want them to learn the art and the science of being able to identify relevant facts, cull them out, and build them into their case conceptualization and their clinical reasoning. So here's one example right here called the Stakeholder Model. This is something that I've developed with a number of other members of our team in the last few years. It's a very basic kind of a thing. We talk about stakeholders all the time. But who are the stakeholders in this case? People or organizations that have a clear vested interest in a successful outcome. What's the perspective of each stakeholder? What do they want to happen in terms of action or procedures? What do they want to achieve in terms of outcomes? How do we incorporate their views and desired outcomes into our assessment, case conceptualization, and treatment plans? How do we know if or how much their desired outcomes are achieved? And how do we communicate with each stakeholder regarding our progress through their assessment, case conceptualization, intervention planning, intervention implementation, and outcome assessment plan? And so this is really a fun exercise. I teach the case conceptualization course here. I'm going to show you what my students, my first year, they're second year students, first year in the practicum, meaning they're just starting to see clients, are able to do. This is also a great opportunity to teach people about the distinction between statistically significant change and clinically significant change. And oftentimes the stakeholders themselves care little about statistically significant change. That goes right over their head. It may not even be relevant. Clinically significant change is oftentimes things that capture a lot more of our stakeholders' views. They're concerned about functioning. They're concerned about developmental impediments and disruptions, et cetera. They're concerned about risky behavior. They're concerned about diminished life prospects, et cetera. If I just simply go in and say, guess what, PTSD symptoms went down, and I view that as the end all be all of my treatment, in many cases, I'm not speaking in a language that my stakeholders really understand or really heavily value. So this is 1 week old. This is a stakeholder model that my students, gave their final presentations last Friday, were able to do from one of their models, or I'm sorry, from their particular case. They brought in friends, the client, friends, employer and coworkers, fiance and kids, legal system and law enforcement, and extended family of their particular stakeholders there. Another is the assessment planning grid. This is something that I published with my colleague, Dr. Julie Kaplan, in 2020. Here are the names of the students who once again presented this last Friday. But mapping out what the study questions are, or hypotheses, identifying the traits or constructs you want to be able to assess, identifying your key information sources. When you're working in chaotic environments, you have to be extremely opportunistic and really a go-getter to go out there and get those types of information that are available. So we're not just subjected to mono-source and mono-method bias. So we teach people about different types of bias that can enter into our decision-making. Types of information we want to gather, self-report, parent observational report, et cetera. Method of assessment, including clinical interviews, phone calls, behavioral observations, et cetera. They're mapping that out. And then assessment intervals, how often do you want to do it? At baseline, during intake interview, intermittently, mid-treatment, post-treatment, and perhaps at booster session follow-up. So this is their assessment plan that arises as a direct question of the study hypotheses. So you can see how this links in with the problem-based learning methodology that we had before. You generate those hypotheses, build it right into your assessment planning grid, and now you have an assessment plan that co-evolves as you're working through the case unfolds. A third is the general learning objective 3, and that is case conceptualization. Can we use these relevant facts to build a case conceptualization, a conceptual framework, and use that framework to evaluate the hypothesized contributions of different case factors and to guide case-related reasoning? So those of you who are science nerds are going to recognize this as a path model. It's rather simple. We've got causal risk factors, things like trauma exposure or bereavement, for example. We have negative outcomes like PTSD or prolonged grief disorder, might be disruptive behavioral problems, etc. We've got vulnerability factors, which exacerbate or worsen the effects. That's what this plus means, the positive effect of the causal risk factor and the negative outcome. Basically, the worse the trauma, the more severe the PTSD, and the more vulnerability factors you have, or the more potent they are, the more that is exacerbated. And protective factors have a buffering effect, which tends to turn that down like a dimmer light switch. So we teach people how to be able to build a working case conceptualization and to take these case factors and to assign them to each of these different conceptual bins. And when they do that, this acts kind of like a template. When you populate it with with case factors, then you have, when you take the template away, you've actually got a working clinical theory. And this tends to evolve as the cases evolve. As you gather more information, we iteratively return to these models and continue to build them out with additional case facts, etc. Now, here is a more intermediary tool that I published on recently. If you take this basic, what we call the check heuristic, these are 4 things to check when you're working through your assessment and your case conceptualization, etc. And you cross-pollinate it with a 4-level ecological model, you get a new thing. And that's what we call the eco-check heuristic. And that is basically, we have 4 different conceptual bins, still have the same causal risk factors, protective and vulnerability factors, and negative outcomes, but they're now stratified by individual, family, community, and society. So we now have a working case conceptualization that's stratified across levels of the ecology. The question is, can students do this? And I can attest to you that they can. So here's another worked example from students. They were doing this, once again, a week ago after a semester-long class, where they learned how to use this among many other different types of clinical reasoning skills. A general learning objective 4 is critical reasoning, and that is, can we use critical reasoning to make judgments about the relative impact of various factors that are hypothesized to influence a child's traumatic experience and their post-traumatic adjustment? So if we're going to be addressing a clinical blind spot here, I'm going to be focusing on diagnostic overshadowing, and that is, can one thing eclipse others? And this is something that I developed with Peter D'Amico. It's a particular case study. This is the Joshua case. We have a 15-year-old intellectually disabled adolescent. He has a prior history of parental death and parental neglect and abuse. His father is imprisoned for gross child maltreatment of Joshua. Treated on an inpatient unit with poor results. He's intermittently disruptive, many seclusion and restraint episodes that resulted in staff injuries. The staff is demoralized, believes he is psychotic and dangerous and should be discharged. And the psychologist then consults with the staff regarding the diagnosis and treatment plan. Bottom line is, the big reveal comes when somebody does a thorough chart review and they identify a history of extensive trauma exposure, and they reconceptualize the case. But initially, the case begins when the psychologist comes to the unit and has them generate their working diagnoses. And they come up with ADHD, psychotic disorder, autism, and intermittent explosive disorder, but they are partially and not fully met. So wow, 4 major diagnoses. And the staff are overwhelmed because each of these calls for a different type of an intervention plan. But we then introduced the question of diagnostic overshadowing, and that is, could these things which are in the foreground be obscuring something which is in the background that they're not quite seeing because there's part of the clinical picture they haven't quite seen or filled out? And that is, we have complex post-traumatic stress disorder, and that is if you can identify these complex trauma related episodes in his life. Think about the first case in the thought experiment that I gave you earlier. If you understand that and the fact that his mother died suddenly of a drug overdose and that his father was heavily abusive and neglecting, etc., then a lot of this suddenly makes sense as complex adaptations to chaos and loss. And this is then really a reframe. It's an epiphany for the staff, and it leads to a much more benign case conceptualization. He's not just dangerous and explosive and psychotic, etc., headed for the prison system, but instead leads to a radically different intervention plan. And he really is able to self-soothe, calm down, and actually benefit from them. And so it's a rather dramatic change in the way in which they see and work with this young man. And he's able to stay on the unit and to improve. Fifth is trauma communication. We want to clearly and accurately communicate appropriate trauma information. So we want to be able to work with our clients. This is a tool that I developed with Chandra Ghosh-Ippen and Bob Pinus. This is a whole other tool. I could spend a lot of time talking about it. It's called the Ecobee framework. We have about 5 different applications for it, but I will focus on one, and that is being able to provide client feedback. And that is when you have gathered information and you're presenting your client the results of the assessment and your proposed treatment plan, you want to be able to present your gathered case facts. You want to also be able to talk about the conceptual framework, that is you're using a CBT or a psychodynamic kind of a framework, etc. Intervention objectives, which are what you want to achieve in treatment. Practice elements is what you're going to do or how you're going to work with the client. You can think about these as strategies. And skills are ways in which you implement those practice elements pursuant to achieving your intervention objectives. In other words, this is how you do it. It's how you speak with your client. It's the language in which you speak. It's your body language. It's the particular ways in which you adapt your language, etc. It's the metaphors that you use. So each of these are a different level. You can think about this as a complex treatment lasagna, where each of these are different levels and they all permeate and they work together in an integrative way. But when you sit down with clients and explain it, you want to be able to explain the empirical evidence, supporting your recommended treatment strategy, as well as the particular case facts, your working conceptual framework, what you're trying to achieve, what you're going to be doing together in order to be able to achieve that. And then also you're using skills throughout the entire process. But that's one of many different applications of this particular tool. And then real world applications. We want to help people be able to transfer this learning to their real life work. And so we're constantly inviting them to reflect on how they're going to apply this to their work and to bring in real life examples to the extent that it's appropriate. So how do we transition people from case conceptualization, for example, to treatment planning? And that is with the Check Heuristic. If you just simply swap out causal risk factors and protective factors, etc., and bring in a primary intervention objective, you can now actually build an entire intervention plan using the same basic conceptual framework. And once again, I can attest, based on my students' own work this last week, that they can do this, as relatively new graduate students, just seeing clients. So we saw rather sophisticated transitions from the working case conceptualization to an intervention plan where they actually selected a manualized intervention using this as their evidence base and their rationale for why they chose that and what their particular intervention objectives were. So how is the core curriculum being used and how does it perform? I'm borrowing some slides from the work of Bob Abramowitz, Laura Katz, and Sonia Dublin. The core curriculum is currently being integrated into a discipline's academic curriculum. So we've got 10 child psychiatry fellowship programs around the country now dedicating time for the core curriculum and childhood trauma training. We're expanding into new disciplines in the current grant cycle, focusing on psychiatry, doctors, pediatricians, medical students, clinical and counseling psychologists, MFT programs, as well as new partnerships with Division 56, that's the Trauma Psychology Division of American Psychological Association, and many different partners throughout our National Child Traumatic Stress Network. In terms of evaluation, We are evaluating a number of different outcomes. We are getting a bit more ambitious in the particular types of questions that we're able to address. Across all mental health disciplines, we find retention of learning up to 2 years post-training thus far. And we published two, actually it's now, the third is in press about looking at core curriculum learning outcomes. I can tell you in brief, master's students in social work rated the core curriculum halfway through their second year as more effective in preparing them for professional practice than training in a manualized intervention. And at the end of their second year, they rated it as, in other words, equivalent in effectiveness in preparing them for entry into professional practice. So the core curriculum is standing up against, if you will, training as usual, which is frankly what we're seeing in many programs around the country. If they're training in a manualized treatment protocol, they call themselves evidence-based, and there's good reason to suggest that. But we also would suggest that the core curriculum can serve as a really great frontispiece or a parallel complement to training and manualized interventions, and that's a great deal of added value. Our own data evidence to date indicates that programs that are receiving people who are trained in the core curriculum love the students, and they create these pipelines that help the programs to place their students in reliable clinical placements. And the supervisors rate the students as being comparatively quite advanced in their readiness to be trained in manualized treatment protocols. We can just simply say before, after, and a follow-up. Essentially, we are seeing improvements across many different domains, including working effectively with traumatized children, using self-care strategies, using trauma-related concepts to work with caregiving professionals, using facts to formulate hypotheses, weighing evidence for and against hypotheses, using clinical reasoning to process client information, understanding the complexity of trauma-related impacts, and identifying relevant trauma-related information. So we're getting good pre to post and follow-up values on that in a study we just published. And in terms of a national evaluation, we're finding statistically significant improvement. More experienced practitioners are ending with higher end scores, which is lovely, but new practitioners are also showing larger change scores. So in other words, both experienced practitioners and novice practitioners are showing significant benefit from training in the core curriculum. In terms of future directions, and I have limited time here, I'll cover this rather quickly. One is our SAMHSA grant. We're going to be focusing on holding regional trainings for basic core curriculum facilitators. We've created an expert panel with Division 56 psychology, trauma psychology. We have a stakeholder advisory group. So we're working with a major organization and have petitioned to the American Psychological Association to establish a specialization in trauma psychology, and that's something we're working on currently. So we're working in psychology to petition and to develop methods to assess core trauma competencies and to publish scientific papers, and that's an ongoing process. We also have a partnership with the University of Utah School of Medicine to adapt and disseminate the core curriculum in child psychiatry and pediatrics, and that would be a good sister program for any schools of medicine that are interested in getting involved in this work. In terms of adaptation, currently what are we working on? We have a brand new disorder called prolonged grief disorder and DSM-5-TR. We have exploding rates of suicide and homicide, for example, and drug overdose, deaths of despair. So we're really trying to adapt the core curriculum to be able to incorporate psychological assessment results. Here's an example from my student presentations 1 week ago, once again, presenting a scored profile and incorporating that into their case conceptualization and their treatment plan. This was actually used as a rationale for adopting a trauma and bereavement focused intervention. A second adaptation that we're using is to address pressing challenges of our time, and that is, we've got COVID and bereavement and prolonged grief disorder. We've got 200,000 children across the United States who've lost a parent to COVID alone. Parental death reduces likelihood for academic success throughout college. In other words, we're identifying 20-year longitudinal effects of an impaired or diminished likelihood of passing every grade in school all the way through completion of college as a function of the loss of a parent in childhood. Each COVID-related death died nearly a decade earlier than expected, and COVID-19 is estimated to reverse over 10 years of progress made in closing the life expectancy gap between Black and white Americans. And coronavirus cases and fatalities are disproportionately common in Black and Hispanic populations in terms of their overall impact, including among healthcare professionals in nursing homes, and also with respect to a negative financial burden. So this is certainly something that is a very salient problem for us. And so we're seeking to create new cases that involve diagnosis of prolonged grief disorder and differential diagnosis with PTSD and with major depressive disorder. So that's one example. And partner with Division 56 to offer competency-based trauma training across the professional life course. We can sort of look at the core curriculum as being a bridge that allows us to cross this chasm between calls for competency-oriented training on one side and creating certification benchmarks that show that you have the competencies on the other. Without the core curriculum, to be honest, it begs the question about how you get from here to there. But with a training curriculum that is specifically focused on building these competencies with formative and summative assessment tools, et cetera, where these things are, the whole thing is built around identifying and building particular types of competencies. We really think that this is a critically important mediator and link in a chain that moves us from calls for competency-oriented training to actually having certification benchmarks and to actually being able to turn out clinicians who are highly confident, have the capacity to be able to work with these difficult cases. And I'll show one final thing is the educational highway model. This is for psychology. It begs the question about how we would do this, for example, in a school of medicine. But we have many different on-ramps. People can come in to undergraduate psychology education, and this is where they get their trauma training, and then they off-ramp to professional practice. Well, we've now described a lot of people that are CPS workers, for example, that move into the juvenile justice system, et cetera, that become parole officers, et cetera. Many people get their only exposure to this, if it's going to come, in their undergraduate years. But we can also think about master's level, doctoral level, at the externship and internship level, postdoctoral level, and professional practice level, et cetera. When you map out every possible on-ramp with every possible in-ramp, there are 15 different permutations here. So that's what we are actually taking on right now in our work with Division 56, is coming up with a plan for these different permutations. It is challenging work. Okay. In terms of conclusions, the core curriculum shows good promise as a tool for increasing mental health practitioners' knowledge and skills related to child trauma, including case conceptualization and clinical reasoning, and further expansion into underrepresented sectors such as child psychiatry and psychology are really needed. That's what we're doing in this new grant cycle, which just began this last November. And paired with continued evaluation to assess the differential training needs and potential workforce developmental impacts across multiple training mental health professional sectors. Okay, and there's my contact information. I think I made it. I'm 1 minute over. So I'd like to turn the time over. Okay. So what I'm going to do right now is I'm going to stop sharing. And so we can have a Q&A. As I always say, questions, comments, or scathing rebuttals are all welcome.
There you go. Thank you so much. That was, that was an information-packed talk right there. And I was just sort of thinking about some of the key takeaways. I have a really strong appreciation for the way in which you talk about the distinction between having the knowledge versus being able to adequately clinically apply the knowledge. And in this area, which is so complex, that, sort of tackling that just seems like such a monumental, gap to tackle. And you've done such a nice job with all these tools and frameworks, and it just seems so useful to me. So I've posted in the chat that if people have questions, you are welcome to put them there. We can also unmute, but I do have one question I'll start us off with, since there are not any in the chat yet. This is my question. So I'm the director of the Autism Center, and so I was really interested in some of your comments about the timing of trauma, because in autism, as people probably know, we oftentimes talk about the kind of the cascading effect that you talk about in the context of developmental delay. So meaning that the developmental delays themselves cause you to go on and have sort of compounded deficits over time because your delays prevent you from accessing, developmentally meaningful experiences that would, that would promote development. So then you layer trauma on top of that, and you're saying trauma kind of causes the same type of effect over time, depending on timing. And so I'm wondering if you can just, kind of talk to us about the impact of trauma in that context, and if you have thoughts about how the effects of just the delays themselves being cascading versus the timing of trauma being cascading, like, do you have thoughts about how that presents similarly or differently, or how we could kind of parse that out?
Yeah.
It just gets so layered.
Yeah, it is. Oh, okay. I have probably about 3 thoughts, and I'm going to try to get them very quickly. One of them is, even from a trauma-informed risk screening and assessment perspective, 2 key points to keep in mind is that kids with developmental delays are at higher risk for exposure to trauma, and they oftentimes are vulnerable to the effects of trauma when it occurs. And so it's important to distinguish conceptually between risk for exposure versus vulnerability to exposure when it occurs. The former carries implications for risk screening, the second for case conceptualization and intervention planning. Point number 2 is I think it really poses an interesting and challenging issue for differential diagnosis, and that is that the same issue with diagnostic overshadowing, for example. We've got somebody, by the way, named Juliet Vogel, who's consulting with us on this. If you want to follow up with an email, we'd love to have you join our little cadre, because we're focusing on this very issue. We are developing a case study, Juliet is, of a kid with developmental delays who's being assessed, who also has a trauma history. And it provides this challenging issue of, okay, what instruments do we administer? And how do we tease apart what we think are the likely effects of trauma exposure versus this developmental delay, et cetera. And they're not necessarily independent factors. They can actually interact in synergistic ways, et cetera. But that's very challenging, even for the very best psychologists that I have met. But it's very, very important work. And so, frankly, that's an ongoing case we're working on. Love to have you join us.
Awesome.
The third, okay, go ahead. And the third has to do with some really great work. What's his last name? He's at University of Utah. He's a developmental psychologist. First name, I think, is Bruce, but he's doing some really good work on short-term adaptations that people make to traumatic stress that leads to long-term developmental consequences. So it sort of allows you to survive, but it curtails your developmental opportunities later on in life. And just being able to recognize, first of all, that these are, to be able to reframe these as positive adaptations that facilitate survival, but that come at a great developmental cost, and recognizing that part of the clinical picture is not just simply identifying trauma and sort of teasing it apart from and disentangling it from developmental disabilities, but to recognize how complex the case conceptualization and the treatment plan needs to be. And that is oftentimes what I like to tell my trainees is that remediating PTSD symptoms is oftentimes the easiest part of what we do. It's the developmental disruption, for example, and helping kids to get caught up on developmental, on lost developmental opportunities or sort of lags in development, et cetera, is also part of the work. Risky behavior and rectifying disruptions in developmental trajectories oftentimes is much more complex and challenging than the original picture itself. But that, for me, I think is part of the broader picture right there. Is we're looking at developmental injuries, not just, if you will, psychic injuries, and to recognize that's part of the broader picture. One last point. I'm sorry, this is 4. Is to recognize, I've done this, I'm happy to correspond with you, but we have a working typology of different trauma-related developmental injuries. Things like, for example, developmental slowdowns, developmental regressions, developmental freezing, for example, and developmental freeze, oftentimes you can't pick up right away, but you pick it up when kids normally progress onto the next stage, and these kids don't. Like, for example, I was in a car accident, say, and now I don't want to drive. Or I was sexually assaulted, and now I don't want to go on dates, et cetera. Or, I lost a boyfriend when I was 17, and now I don't want to form an intimate relationship when I'm 19 that's more serious, et cetera. So there's different ways in which you can find these developmental injuries. And one of the things that's fun is to introduce the mind bender of precocious developmental accelerations. And those are very common. You have sexually, abused kids who run away from home, for example, or take on these precocious developmental tasks, oftentimes for which they're ill prepared. So that gets us right back into the developmental model, where are they at, what developmental competencies they've taken on and achieved, et cetera, and to make sure that the developmental tasks they take on are sort of commensurate with their developmental competencies. Okay. Hope that I didn't overdo it. Okay. Other
No, I
questions,
think that's
comments?
great.
Thanks.
Yeah, and I would guess that, yeah, all those different, I mean, those different points have really, I would guess, very broad application also, depending on kind of, my framework is autism, but I would guess a lot of people, could sort of take that into their clinical practice in a variety of ways. So there's a question that came in that I'm just going to read. The question is, I wonder about balancing the need for deeper learning and knowledge base, especially among trainees, with the urgency of getting nervous clinicians already in the workforce to go ahead and screen youth, irrespective of deep expertise. Kind of how do we think about that balance is the question.
My immediate response is to help people understand where they are in terms of a cog in the wheel in a trauma-informed system. And that is that you can systematically screen for and identify and be a really part of that that security safety net without necessarily having to possess a lot of in-depth clinical expertise and how to work with them. So we do the same thing, honestly, when we're working with teachers, for instance, or school-based counselors, some of which who actually don't have either the expertise or they don't even have the sort of the logistical materials that they need. They don't have an office space where they can actually work with people and run groups, for instance, in some settings. So, but how can they see themselves as part of a risk screening referral network so that they can identify these kids and they know to whom to refer them? But that being the case, I want to underscore that there's a lot that a well-trained clinician, even one who's not well-trained in trauma or bereavement, can do with kids. We ran a randomized controlled trial over in Bosnia, for example, and we found that school counselors who are over there doing psychoeducation and skills building and teaching kids a support recruitment skill and basic thought restructuring, replacing negative thoughts with positive thoughts, et cetera, that those had a significant beneficial effect. And that was actually the contrast group for our treatment group, where the kids met in treatment in 10-member treatment groups with specialized treatment. So both groups benefited. Thankfully, the specialized group benefited more. But bottom line is, even basic outreach with psychoeducation and skills and so forth had a significant beneficial effect. And I'd like to underscore that this is not just something where you identify through risk screening and immediately punt. There may be a lot of good things that you can do with some of the transdiagnostic types of skills, for instance, that can be a great help as well, so that you don't overwhelm your trauma specialists, et cetera, if there are things that you could do. And part of that has to do with having assessment tools that allow you to have gradations, so you can identify a severe case versus a moderate case, because frankly, you may be able to do a lot with moderate distress cases, for instance, that don't require a lot of serious work. Now, that's part of what we do in the core curriculum is helping us to identify what a complex case presentation looks like, including issues of comorbidity between PTSD and prolonged grief disorder, major depressive disorder, et cetera. Obviously, the more diagnoses that are in play, typically the more complex the case presentation. But I underscore, I'm saying this for the third time, there's a lot that frontline practitioners can do to help these kids, especially those who are in the moderate distress range.
Yeah, thank you. The person who posed that question is actually one of our local clinicians who has a lot of expertise in trauma. Nat, I don't know if you want to unmute and if you have any follow-up comments or questions to your question.
No, just really appreciate the answer and the resources. And, I'm not seeing a lot of other questions here. I don't want to hog the space, but I'm also so curious, Dr. Lane, about the how you would encourage clinicians to prioritize care when kids have so many moving pieces, so many things going on, so many compromised supports, and we don't want to overburden the families, right? We don't want to overburden sort of foster parents or overload the clinical wagon. So do you have resources in your many toolkits here for guiding that sort of conceptualization and prioritization of interventions?
An excellent question. My immediate response is fall in love with NCTSN and go online and get trained for free in the online training. They have psychological first aid, but the one that I'm recommending for you is skills for psychological recovery. Skills for psychological recovery, and heads up, I'm one of, I think, something like 10 authors on it. But it's developed actually for FEMA, for after the immediate acute intervention, a disaster period. You've got a lot of people who are still suffering distress, but may not require specialized therapeutic intervention. So skills for psychological recovery, to be honest, is a wonderful toolkit of evidence-based treatment components, for example, like, thought challenging. One of the things that I worked on that I'm especially happy with is the social support recruitment skill that helps people to identify who they can go to for different types of support, et cetera. So it's very, very practical, but it's still embedded in theory, by the way. It's social provisions theory, if you want to get nerdy with me on that. But anyway, I would say it's a great running start. Follow up with me if you have other questions. There are all sorts of drill downs that I could go into, but it's the basic question about how many clinical issues are they facing right now, and the key question is, which appears to be the most potent causal contributor to functional impairment, risky behavior, and developmental disruption. So if they've got PTSD, if they've got prolonged grief disorder, if they've got major depressive disorder, for example, if they have, ADHD, this has a basic decision-making template that helps you to sort of think through and say, okay, there are a number of things out there, but which appears to be more when the tire hits the road? Which of these symptoms seems to be most strongly linked to functional impairment? So for example, PTSD is oftentimes associated with sleep disruption. If the kid, for example, is missing a lot of sleep, they wake and can't get back to sleep, et cetera. They're chronically sleepy at school. They can't pay attention. They're falling asleep in class, et cetera. That might be one way that would lean. And by the way, I didn't talk about the seesaw model, but that's another decision-making tool. But you sort of say, okay, what do I treat? Well, that would go on the PTSD, go with PTSD side of the seesaw model, where you say, you know what? Sleep disturbance, physiological hyperarousal, for example, they're constantly aroused. They're having a difficult time, settling down. They complain about impaired memory. Their memory isn't working like it did before. I did a lot of work over in Bosnia. We got 16-year-olds complaining about impaired memory. You're supposed to see that when you're 70 or 80, but you're seeing kids. And for me, that it seems to be logically connected to their traumatic experiences, many of which were absolutely horrific. So is that making sense as a general kind of a heuristic tool? Which appears to hit the road? Okay, great.
I'm seeing a thumbs up there.
Okay.
And that is perfect timing, actually. We're at 9:20, which is our full stopping point. But thank you so much. Your knowledge, but also your passion for the work is really evident. And I would guess that you'll be hearing from quite a number of people who
I'll give you all
are
the thumbs
interested in,
up. There you go.
some of those follow-ups. So thank you. Quick
Thank
reminder that for our fellows, we have our developmental influences seminar starting at 9:45 on this same link. And otherwise, thank you so much to everybody who attended today.
Good, thank you.
I did want to point out too that in the chat is the link for this set of resources, which is very rich and deep. So I encourage people, if you can open up that and pull out that link and make it a favorite, then you can go back to it later and explore it. It's very rich and deep.
Yeah, those are your tax dollars hard at work. It is free.